Good evening. Today we are going to talk about why do opioids sometimes fail. Visit my website www.painfreepartha.com and my YouTube channel Pain-Free-Partha. And all the slides, around 400 slides are there, are freely downloadable and editable for free. So we can use the services of www.painfreepartha.com and YouTube Pain-Free-Partha. So a 65-year-old male with 25 years of history of diabetes. Now he has got a severe pricking pain in the feet and palm. Okay, you are given injection morphine IM. What do you think has happened? What happens? There is no relief because it's a neuropathic pain. Opioids act better for nociceptive pain. Nociceptive may be either somatic or visceral. Appendicitis, cholecystitis, also nociceptive pain, but visceral nociceptive. Here, if you have an injury, bone, lung, etc., it is bone or muscle, etc., it is somatic. So this is not going to be acting for neuropathic pain. Now we go to opioid tolerance. Where also the opioids may not work. We think like body's opioid receptors have become desensitized. They have become worn out. We can see the key and lock, no? Key lock has become the key has become worn out. It is not going into this thing and is opening the click. Patients require increasing dose to achieve the same level of pain relief. This is what is called tolerance. It should not be confused with dependence or addiction. I will come again. Resistance, tolerance, dependence, addiction are four different terms. Now, what we are mentioning about is opioid tolerance. We take opioids for some time, and for example, a post-operative pain. He's taking 7 milligrams or 5 milligrams of morphine for first 2-3 days. It is not working now. It's not decreasing the pain. We escalate or we increase the dose to 7.5. This is what is tolerance. The opioid receptors have become less responsive. So we need 7.5 milligrams to produce the same analgesic effect. This is what is called tolerance. Now we have one more example. For example, a patient with advanced cancer. She takes or he takes 10 milligrams of morphine every fourth hourly. And after some time it is not working. She or she takes 30 milligrams. This is sometimes opioid tolerance, sometimes the cancer disease progression affecting the nerves. Now, day one, you may need just 1 cup coffee, and after some weeks, you may need to get that refreshed only with 2 cups of coffee. That time, sometimes we go to snack bar or coffee bar and take double coffee, sir. We want double coffee. That means you have gone into tolerance. Opioid receptor changes and neuroinflammation. These are the two mechanisms. So opioid receptors has changes, there is beta receptor binding, arrestin bind, so many things that happen. So this becomes desensitized. Here there may be a neuroinflammation producing so many cytokines. So this is called opioid tolerance. Now we know how to prevent it. Start from 10 milligram TDS. No, start with 3 or 2.5 milligram TDS. So use the lowest dose. Sometimes add paracetamol with morphine, add amitriptyline with morphine. All these things, add one block with morphine. So, or sometimes we can use morphine for 5 days, tramadol for 5 days, all these things. Unnecessarily don't increase. So, for example, this opioid increase from 5 to 7.5 may not work. We may know. Don't increase the time. So, again, monitor regularly, add blocks, add ketamine, add dextromethorphan, something like that to prevent tolerance. Now, this is about tolerance. Start with some dose. It is effective. Now we need increased dose. That is tolerance. The first dose itself is not effective. That is resistance. The first dose you put, that is not working. That is what is called resistance. Opioid receptors do not work properly. They are not working. There may be genetic differences. There may be, it is not neuropathic pain induced thing, but diabetic neuropathy changes the pain pathways, making opioids ineffective. See, for example, neuropathic pain, opioid is not effective. That is a different issue. Diabetic neuropathy makes the pain pathway change so that a nociceptive pain also is not working with opioids. That is what is called resistance. Inflammation in the nervous system. Pain pathways can become overactive. Opioid surface move away the cells. Certain multiple sclerosis. Brain and spinal cord pain control is altered. There are so many things. Now we can see fewer opioid receptors, genetic changes, neuropathic inflammation, certain diseases like diabetes, HIV, multiple sclerosis, they become overactive. All these things are mechanisms of opioid resistance. That means the first dose itself is not effective. So genetic resistance, a patient with diabetic neuropathy, yes, all these things are examples of opioid resistance. A patient with HIV induces distal sensory pain relief is not good. Multiple sclerosis with central neuropathic pain. Morphine produces only modest relief. Sometimes they call it as codeine responder, because non-responder, because codeine has to be converted to morphine. If that is not happening because there is some genetic changes, then this is a pharmacogenetic opioid resistance. It is a tolerance. Now, coming back again. Decrease the dose after a repeated prolonged dose. The first dose itself is not effective. It takes some time, but it based on first drug. It is receptor desensitization. Receptor is not working. Dose escalation, increased opioids, all will work, but it will not work here. Now we know opioid tolerance, opioid resistance. We go to third, opioid dependence. So normal physiological adaptation in which the body becomes accustomed to the presence of opioids. If the opioid is stopped, withdrawal symptoms will occur. That is the difference. Tolerance is not associated with withdrawal symptoms. 55, for example, pneumonia, mechanically ventilated. He's an ICU. He starts infusion of fentanyl and he gets 10 days. Then after that, he stops. He is extubated. He develops restlessness, sweating. All these things is dependence. So restart fentanyl and gradually taper it. In cancer pain, sometimes they are physically dependent on morphine because of long-term therapy. But this is not addiction. I'm coming back again. Opioid addiction is a chronic brain disorder in which the person compulsively takes this. And I know some doctors using 14 IV, some nurse using 14 IV, even though they know that it is causing harm. They are using when there is no pain. These are the two distinct differences between addiction and dependence. Addiction means the person knows that it is causing harm and he uses when there is no pain. That is what is addiction. So, addiction for underwent spinal surgery and received morphine. After discharge, also he said there is no pain. He continues to take opioids from doctors. He has no pain. His family is affected. He is affected. That is what is called opioid addiction. Opioid dependence means for pneumonia ICU, he takes for 5 days and then to stoppage, he may be restless, start the fentanyl again at a lower dose and slowly withdraw. This is dependence. The body needs the opioid. Basically, the mind is in compulsion. That is the difference between opioid dependence and opioid addiction. Like someone who feels uncomfortable when a long-standing daily routine is suddenly interrupted. Like someone who cannot stop a behavior even when it is harming him. Now, this is resistance, means first drug no use, genetic problem. Usually, higher dose is not going to be useful. Withdrawal, resistance, no. Clinical example, diabetic neuropathy induced now changes. Tolerance means 5 doses is okay, then he needs excess dose, and withdrawal symptom is not there. Dependence means body adapt to opioids process. A physiological adaptation. You see, it is more of neurobehavior and psychological. Needs higher dose, not necessarily, but often due to misuse. Withdrawal is be there, withdrawal will be there. ICU patient after prolonged fentanyl infusion. But here addiction means the patient is addicted and it is causing harm to the patient and family. There is sometimes called opioid-induced hyperalgesia. What is algesia? Pain. Analgesia, pain relief. Algogens, pain-causing chemicals. This is what is called the terminology. Hyperalgesia means more pain. Now you give, there is pain, you give opioid, there is more pain. That is what is called OAH. Sometimes pain may be, you have a surgical incision here and you give opioids, and the pain may be increasing here also. So more common with high opioids, seen with fentanyl and fentanyl infusions. It is different from tolerance, because in tolerance, if you increase the dose, it will work. In OIH, if you increase the dose, it will not work. So not every patient with poor analgesia has tolerance. Another thing is, don't think that opiates will work for all. This dose of morphine I have given, it's not working. Yes, there is something called tolerance, there is something called resistance, something called dependence, something called addiction, and something called opioid-induced hyperalgesia. Don't think like that. Opioid always will work. Thank you very much. Visit my YouTube, Pain Free Partha, and thank you all for patient listening.